sports medicine world. But when I was looking at some of the sample questions for the boards that we're taking, I think there is somewhere in betwixt for the granularity. So I tried to go a little more in depth. Also for this slide deck, I left like all the things that I've taken in the notes so I can send you the entirety of the slides. So there's a lot of description for review for the boards side of things too, if that's helpful. And
Yeah,
so that Joey will have a copy of it too.
I also I'm recording this.
Oh, excellent. And then if at any point, because I feel like every time I'm like going down a rabbit hole for some joint interrogation, there's stuff that I'm missing that's like mentioned somewhere else. So please, especially Stephanie, at any point jump in, because this is something that I've been developing more of my knowledge of and am not by nature an expert in. But it's cool stuff. All right, let me see my slides.
Absolutely suck at MSK.
Yeah, I don't think it's not my strongest, but it's something I want to get a lot stronger in, not only because of like obviating need for other imaging, but you can get more imaging. Like you can get more information than you can before I had ultrasound. So I should have taken, this was like a while back, but like diagnosing like tendonitis was, it's just like really nice for a patient to be like, oh, I think there's like some calcification in there. So there'll be some caveats, there'll be some things that aren't totally explored, but we'll get somewhere today. So we'll start with the shoulder. There's going to be two parts for this of talking about dislocations later, but I think we can do a lot to interrogate the rotator cuff and just the bony structures of the shoulder as well. This POCUS 101, a lot of this section comes from POCUS 101 because they do the deepest dive that I found sensical, even more sensical in some ways than the core ultrasound lecture on the pathology of the shoulder. So I definitely think this is one of the cards that's worth like looking back towards. And just that the idea of what we're focusing on is just thinking about the very simple idea that it's the head of the humerus that's sitting within the glenoid fossa, and that there's like the labrum that sits around that and stabilizes the head of the humerus, and that labrum is then associated with the fibrous, like with the joint capsule and the bursa that like lines that's lining it with the synovial membrane. So we're only gonna, when we talk about bursas, I only kept this to just a single bursa of the subacromial subdeltoid bursa, just because that will come up when you're looking at other websites and you're looking at videos. That seems to be the most recurrent bursa. And then for the muscles, we spend a bit of time on the supraspinatus, and then you'll get a little bit for the infra and the subscap. And then ideally, when you're positioning these patients, in like an office, it would be like on a backless stool, but this is going to be one to have them be sitting up, and there'll be different positions that we'll go through that can help you further evaluate the different aspects of the shoulder joint. Oftentimes we'll be using the linear probe, but for some of our patients that have like more adiposity between the skin and the joint is going to be the curvilinear probe. And an approach that I really liked, that because I feel like sometimes when I'm doing the shoulder, and you guys might feel the same way, unless I'm doing it specifically for just a dislocation, I'm a little bit all like kind of just cruising around, just like looking at parts of the shoulder. And I didn't really have like an organized approach to it. And there's certain things that you'll see in each part of the shoulder. And also too, when I'm doing my physical exam, like I know we studied all the different movements that you can do to kind of locate where the problem is. I'm not great at the actual shoulder at all. So this gave me some kind of like method that I can go through that's a little bit more organized of an approach for looking at the different parts of the shoulder. So this is also, I think, a good way to be a little more structured in your shoulder interview. So the anterior shoulder, basically, like people think of this as the home base of the shoulder, where it's a good starting place, and it's pretty simple in what you're looking at. You're basically looking at the long head of the biceps tendon. And if you're doing image review and you're trying to orient yourself to where the greater tuberosity is, it's the one that has the little divot in it. So when you're just trying to orient yourself in time and space, you're going to have the probe marker facing to the patient's right, because there's going to be some changes in what we consider long and short axis when we're talking about shoulders, because it's going to be, or we're talking about any joints, because and tendons and MSK in general, because your axis is in regard to the thing that you're looking at. So for this initial view, you're going to be seeing the greater tuberosity of the humerus and the lesser tuberosity, and you see that has a little divot in the greater one there. So then you, sorry?
No, you're good. You're good.
No. So if you then flip your probe to where it's not in the conventionally in the transverse plane into the longitudinal plane, then you'll see that tendon of the biceps tendon. You'll see that in the long axis, and then kind of up here you'll actually see that subdeltoid subacromial bursa that kind of comes into view in the more superior aspect of your screen. And then over here, do we know what muscle this is over here, Brian?
Over where?
We don't see
Like
this.
oh wait, oh sorry, let me put my little guy on. Yeah, you don't know what I'm thinking? Come on. No, this one here.
The delt.
Yep. So then you see the deltoid that's overlying those structures. Whenever I'm going to only mention this once, because if you just mention it once, you can apply it to the rest of the joints and the rest of the tendons, is that these views are very much prone to anisotropy, just because of the angles that you're working in. So it's really important to just make sure you have the right angle of inclination, and then to do appropriate scanning in both the longitudinal and the transverse planes to ensure that that what you're seeing is actually a pathology and not just an abnormal, just not just your angle being off, not just anisotropy. So if you see here, this is actually going to be a normal biceps tendon. So just to remind us again, we got the greater tuberosity, lesser tuberosity, and then you've got the biceps tendon that sits right there. And then for most of these joint interrogations, you want to have some degree of dynamic scanning. So for this, if you're trying to evaluate the long head of the biceps tendon, you can have them just internally and externally rotate their arm, while they're like at the shoulder, and then you can see if there's subluxation of the tendon, and you're just able to get a better idea of how that tendon is moving within the groove. But really, for the long head of the biceps tendon, you're looking for subluxation. Very similar, like a very minimal change that you would do in this view to look at the subscapularis is like you would have them when they have their forearm is externally rotated, you have their palm up and you keep their elbow kind of fixed down at the area of their iliac crest. And then you would go to the short axis that you're looking at for the long head of the biceps tendon, and then you just slide your probe medially with the indicator pointing to the patient's right, and then you should be able to see subscapularis come into view. Once you do that, you want to fan the entire width of it to see if you're seeing like any hyperechoic areas, hypoechoic areas, any evidence of calcifications. So as you can see here, you see the biceps tendon kind of disappearing to the left side of the screen, and then you see the subscap right there. And again, we always like to get things into both axes, so you would just then rotate the probe 90 degrees so that you're in now what would be the transverse view, because you're looking at the, because we're talking about the actual structure that we're looking at. And you can also see if there's any abnormalities within this view. And this is just another view of that as well. So like
is like the anatomical man, and then the supraspinatus is like the supermodel pose.
Yeah. So those are really like in that first view. So that's the anterior view. So you're looking for the long head of the biceps tendon, and you're looking for the suprascap. So now we will go on into when things run afoul and the humerus is not very funny. So what do we just think of this view without me telling you anything?
It
looks it looks
I'm saying it looks
It's-
big, like the actual like biceps tendon looks like large. It's not like uniform.
The
Yeah.
fascia looks thick right over it.
Yeah, so those are really good. So you're pointing out a few things. What do you think about the actual like echogenicity within the tendon?
It's like disrupted. It's not.
Yeah,
It's not
so
uniform.
yeah, you've got like this kind of like mixed echogenicity. You've got some areas that are more hypoechogenic. And as you said, it's not kind of sitting flush within that groove. That's the bicap groove there. You're seeing it kind of bulging out. So that's actually a tear within the biceps tendon.
Hmm.
What about this one? Some of these will be, there's a lot of just still images within the MSK world. So that'll be what you'll be interpreting.
Maybe fluid around it.
Yeah, this little stripe here, I agree.
Yeah.
And what about where it's sitting?
It's sitting. Would that be a little lateral then?
Yeah, so if you see it either going lateral in this case, or if it's going medial, like it should just be sitting right in that groove there. So it can actually dislocate either medially or laterally. And just for additional knowledge, that's often going to be associated with tears of the subscap itself. Of the subscapularis tendon, I should say, or just other rotator cuff injuries. So you should be seeing it sitting right in the bicipital groove. If it's not, then that could be a subluxation. And then too, you can get this little, like you'll get a little hypoechoic groove instead of just it looking like the normal echogenicity. But again, always important to keep with the fanning so that you're not accidentally misinterpreting anisotropy.
Mm-hmm.
All right, what about this one?
That's a.
This looks very elevated and looks big, with a little bit of fluid inside of it.
And at least that maybe I don't even know if it's going to be considered fluid, but I agree that it's just like it's more hypoechoic within the body of the tendon, and this is in the short axis. And if you see that, if you see these little bloops of hypoechogenicity, that can be indicative of tendinosis or even tendinitis. Especially if then you're combining that with the history of people doing like, I feel like this whole lecture slide is just about injuries that my husband's had doing carpentry when he was younger, of these like repetitive overhead motions. You'll see that a lot, and they'll have the pain will be reproduced when they're lifting their arm or you're applying pressure with their hand over their head too. So you can see that, like you said, there's that thickening there, and then there's that, you can have like some increased echogenicity. Oh, let me get my little guy back going again. My laser pointer. My laser pointer disappeared. Oh, there it is. Where you have a little bit more hyper echogenicity and like the borders of it as well, that can kind of clue you in to what you're dealing with.
Is that just more distal on the arm? Like, was the actual like tendon? It looks so much bigger in this view compared to like the other views. Like,
I don't
it
know
looks,
if that's just from it being like inflamed, or if that's something, because really the bicipital groove is a fairly small
Yeah.
space, but
But-
you could
but
see
it's
where this is like not as
like
deep of a
down,
groove as you
So you're
get.
getting more of the muscle belly,
Yeah.
or like the start of the muscle belly.
Yeah, I would agree with that. And again, it's like hard. Like I was trying to find like a whole bunch of. I think if that we want to do something to Nick, well, if we're just like maybe more diligent for doing some of these exams, there's like a weird dearth of good images online for MSK pathologies for ultrasound. So I think we'd have a lot to add to the imaging world if we were like maybe taking more of these and getting a little bit more of an image bank for the MSK stuff.
Yeah. All right.
What about this? Just your thoughts.
So this looks like it's
Torn.
like looks like it's in the right spot, location wise. It looks large. There's like hypoechoic area surrounding the tendon, and
Yeah.
then there's a whole like collection on the side.
So if we
Yeah.
ignore this side for just a second and we just look at the tendon itself, if you were to see this in like a finger or something, what would that maybe clue you into? Or you've got the
Abscess?
tendon, not abscess if it wasn't a tendon, but if you have a sheath tendon that then has like kind of edema within it,
Or like
Like,
tendonitis.
like a tendonitis, yeah, yeah. So this is like actually a tenosynovitis. So
Hmm.
whenever I think of like there's like a tendon sheath with edema in it, that kind of has a similar appearance regardless of where you're looking. So this would be a tenosynovitis. And then over here, which I wouldn't have known without having been told this is actually like the surrounding bursa. Um,
That's what I
yeah,
mean, like
so.
a hematoma.
Yeah.
Yeah, and like that can also be associated with it, where that SASD tendon gets a little bit more thickened as well. Okay. And if there's like problems within the tendon itself too, they can even have tendonitis as well, because the tenosynovitis, when you're thinking about the sheath, the edema within the sheath.
Yeah.
And then this one's like a tough one. I'm just gonna see if you can just. I wouldn't have gotten this one necessarily, but I think it's something that you might see.
This isn't subscapularis, is it?
Yeah. So this is so now, because if you remember, like we're gonna like when we're getting our view for the subscapularis, we're getting that long head of the biceps tendon, and then we're sliding a little bit more medially. So this is subscap. And this is very subtle, and these are subtle findings on ultrasound, but this is a tear within the subscapularis. A lot of times they're like hidden. So you'll just to be mindful if you're seeing these like hypoechoic defects within the tendon.
That little.
Um,
Jeez.
yeah, so but then you see there's a little edema here too, that's kind of like right at
Yeah.
the border of the
Yeah. As I say, I
um,
see just the obvious one. I was like the one where the arrow is pointing is like
yeah.
very, very subtle.
Yeah, so it's like not so like just like kind of like if you're seeing an effusion, I think would be my takeaway. If I saw an effusion around the biceps tendon, I might just cruise around a little bit to see if there's some other associated injury, would be my one takeaway for that.
Mm-hmm.
So we've done the anterior shoulder now fully. So the anterior shoulder is going to be the view for the long head of the biceps tendon, and then the suprascapularis, or the subscapularis, I should say. And then now we're moving to the superior shoulder. So of the A, now we've moved to the S. And for this one, your patient's sitting, and you're going to have the probe kind of sitting up on their shoulder. They're going to have their elbow by their side, bent at a 90-degree angle, and they're just going to keep their hand resting right on the thigh on the same side. And you're just basically finding you're going along the clavicle until you get to the little notch to get to the AC joint. And that's really what you're interrogating in this view, is the AC joint. And you're just looking for fluid collections or if there's some irregular margins. So it's a pretty simple study here. You have your chromium here and you've got your clavicle there.
I don't know if we QA'd it, but I have that exact image. It was a lady
Nice.
that fell. She had a lot of pain over her AC joint and she had like a little fusion around it.
That's awesome. Yeah. So again, not a ton of images for this. So that's cool if we have some more of those. And then for the dynamic scan for this is you're going to have them kind of reach up for their opposite shoulder. And they're going to try to keep their elbow bent and kind of close to their body. And what you're looking for is if that's a good way to see if there's an abnormal width. If it's like, more than 3 millimeters of joint space as they're doing that movement, that can also be indicative that there's some joint separation. Yeah, so now we'll get into the pathology for this. So I'm not going to ask like what is this here?
Needle.
Foreign body.
That's a needle. Yeah, it's a iatrogenically placed foreign body. And what do we think is going on here?
Hematoma block.
So this is
Or-
interesting. Like this is just what you see without trying to interpret like what it could be, of just description from an
There's-
ultrasound language.
Hypoechoic collection, like fluid
Yeah, so there's like, yeah, you're bordering on anechoic, it's fluid there too. This is actually like you can find cysts in this area. You can definitely get effusions not from cysts, but this is not an uncommon place for people who have joint degeneration or people that have chronic overuse injuries or prior other injuries to have little like cysts that form there.
Mhm. Okay.
And then just descriptors of what we're seeing in this view.
I mean, it looks like a widened space between like an AC joint. And then like, I feel like you can see pretty far down. Like you're seeing like a lot of different layers of soft tissue between the joint.
Yeah, because you're getting
Uh,
these like little like you're getting these like mixed hyperechoic patchy areas,
mhm.
in addition to these like hypoechoic areas in betwixt. And you can see that in somebody who has joint degeneration. So I agree with what you're seeing, but if you see these things, especially if you see this like these hyperechoic patchy areas there, too, that can be indicative that there is joint degeneration.
Okay.
And then what about here? This is just kind of a weird image, but just if you were to have some thoughts of what these arrow signs were pointing to.
Kind of like a hyperechoic area where like the lower arrow and like hypoechoic collection at the top arrow. So
Yeah,
maybe
we
like
see these. Yeah, when we see these little hyperechoic things in other spots, what do we usually associate them with, or what are one of the things that we associate them with?
I mean, maybe like a
Yep,
calcification.
exactly. Exactly. So you can find these little calcifications in the AC joint and you've got the widening, like you were saying as well. So this is somebody that has some degree of joint subluxation, and then they get these post-traumatic calcifications. And then what about up here?
I mean, would that just be like another fluid collection from like
Yep,
an acute
effusion.
process?
Yeah. Yep, and that's a post-traumatic effusion with like the overlying effusion there too.
Mhm.
Okay, so that's really like the one thing you're looking at in that view. That's the view that the anterior shoulder is how you're going to be looking for I'm sorry, the superior shoulder is how you're going to be looking for the AC joint.
Mhm.
So then the next one of our ASAP protocol is anterolateral shoulder, which is a little bit different in some of the angles that you're shooting for. So this is something called the crass position is what you're going to put them in, which basically you're going to have them take the ipsilateral hand of the shoulder that's bothering them. And basically like it's almost like they're putting it in their back pocket. And it just makes those structures more visible. So put their palm flat against their posterior iliac spine, basically where they'd have their back pocket. And then you're going to put the probe over the anterior shoulder, but it's going to be there's two axes for this, and one is going to be the oblique longitudinal axis, where you see it's kind of like the probe markers pointing towards the patient's head. And what you're looking for is this is how you're going to look for the supraspinatus, and another way to look at the subacromial subdeltoid bursa as well. And then you can then kind of move that probe as well to get a long axis view. So if you're kind of in this oblique angle, then you can move into this. This is going to be more of a transverse angle for it. That's actually going to be long axis because it's long axis in reference to the supraspinatus, if that makes sense. So to go back, like, so this is just like kind of fanning through that supraspinatus. And it's just like with anything with muscles, you're just looking for disruptions, you're looking for fluid collections, you're looking for evidence of tears. And then you're doing the same thing. That was the oblique long axis. Now you're doing the same thing within the long axis. And you really just want to make sure that you're just focusing, like really this view is really just a focus on the supraspinatus, and to do that just ensure that you're doing a good fan through as well. Sorry. And then for the dynamic scan for this, you're gonna get to that long axis view, which is this view here. and then you're just going to have them abduct the ipsilateral arm, and then you can see like the supraspinatus, you can see the muscle, and you can see the tendon to just see that it's like moving along that ridge. Some people, and I think I have some images, like you can get impingement of these, so it just doesn't move well, or if it kind of moves and then it goes pop. People who get those like snaps of those tendons, or if they get fluid collection, like a bursal fluid collection, then that all kind of points towards they might have an impingement.
Mhm.
So I think I have a picture of that coming up here. So this is like the one I could find for the impingement. So you will see like there's this kind of like, I won't quiz you on this one because it looks kind of weird. I don't have a full grasp, but if you see like there's like this bunching that's kind of happening, like there's like, it just like in this other image, let's see, everything is like moving, like is nice and like smooth looking.
Mhm.
And then if you were to believe me, this would be like a little bit hypoechoic and just kind of like more bunched up.
Yeah, I can see it.
Yeah, and on this one too, what do we think about this one? This is when we're looking at this supraspinatus.
I mean, it's not uniformly the same. Mhm.
Yeah, so yeah, like so
Like the
you've
same
got some,
diameter almost.
yeah, you've got some changes in the diameter, and then additionally, you would describe this probably as being more hypoechoic. So what would that make you just think when we're talking about muscles and tendons?
But this, I mean, really wouldn't be like an impingement. Maybe
A
like an
tear.
acute process, like we had like a tear or a strain.
Yeah, exactly. This is a supraspinatus tear, where you get these little hyper, like I mean, sorry, you get these little hypo and anechoic areas, and you get that kind of deformation of the normal shape of things. So exactly, so you can see that there's a supraspinatus tear, and then this one tells you what it is right there, which is helpful. Of where you've got this stripe up here that's some fluid within that, the one bursa that we choose to care about. All right, so the last piece of the ASAP thing is the posterior shoulder, which I think in some ways we're more comfortable with because we're using it a lot when we're looking for shoulder dislocation or we're looking for reduction.
Mhm.
So, but if we wanted to look at some of the other structures, we can look at the infraspinatus and we can look at the posterior labrum. So these are like the kind of injuries I think a lot of people that have chronic shoulder pain end up coming in with. And you're obviously going to be behind the patient and they're going to put their palm up, resting on the same leg. And you're going to find their little scapular spine. You're going to put the probe in the transverse plane so that you can see the infraspinatus tendon. And I'll show you like before, like I can show you what we're kind of, if I can get my little thingy to work again here. Oh, this one will be easier. So you've got the scapular spine, which makes sense in terms of what it's corresponding with. Always easy if you just take the humeral head as your kind of anchor point. You get your glenoid fossa, and then you get your infraspinatus muscle, and then you still have that deltoid that's kind of sitting as a glove over the entirety of the shoulder. For a lot of patients, and I think when I was hearing what Avila had to say is that for the even not for just the looking at the dislocations, but that this is a good one to maybe switch to your curvilinear probe, just because of the depth that you have to transverse. So a lot of times we'll start within this transverse plane and then we'll switch into although they're using linear probe in this one, we'll switch to the or the sagittal view. And so what we're looking at here is like, I can see if you guys can get this, like, 'cause it's just kind of good. I feel like I have to look at a lot of these when I'm just getting myself oriented here. So what do we think these straight arrows are pointing to? If we go back to what we were looking at in the transverse view, and then where we've got that infraspinatus there, of what would we maybe be looking for up here?
I mean, is that?
You see it kind of
Would that be this?
connecting down here too.
creeping. I mean, is that just the like most inferior portion of the delt at that point?
You're actually seeing the infraspinatus tendon there, which when I was going through, like, so you've like, if you kind of thought about like its insertion points and you've got this infraspinatus muscle, and then you're flipping your probe up here, and like on the top of the screen over here, you have the bony parts of the humeral head up here, and you've got the parts of your like your spinal glenoid notch there. And you see that like how it kind of trails off there. That's just a way to identify that you're looking at the tendon there. So I just see we're just seeing, you see that tendon kind of the same in this dynamic view over here, and then you've got your deltoid up here. And really what you're looking for, especially I feel like for us, for emergency physicians, is if there is disruption of something, then you can kind of nail down what exactly looks disrupted, but just making sure that everything looks nice and clean. All your bundles look bundly, and there aren't any fluids. But should you find some kind of problem, you can see like these are just like pretty subtle. And we'll get past these subtle things. I'm not trying to torture you guys with subtlety, but just really the idea is to be mindful that if you see these areas that are hypoechoic, especially because most people, I'd say even more so than legs, most people have two shoulders, right? Like I feel like there's a lot less like shoulder amputations happening. So like you really always have two shoulders, which is really great. To see if one side looks more hypoechoic than the other. So what this is actually looking at is that little area of labrum that's like hypoechoic, and these people get a lot, like we get a lot of patients that have labral tears. Maybe we're not diagnosing them, but I think that people that have shoulder pain are really frustrated, and a lot of people that maybe don't have access to orthopedic associates, people who are manual laborers, people that are just kind of to the end of the rope. So just like being, you know, you don't have to nail down the diagnosis fully. Be like, yeah, you might, you know, like from my knowledge, you might actually have something going on with your labrum there. And then what do we think about this?
It's like a large hypoechoic area. I'm just not sure where that is. Is that?
Yeah, so let's say it's like kind of, it looks kind of like circumferential, like it's got little circles.
Yeah.
So when we see something that's kind of circumferential and fluids, what do we think of? What pops in our minds?
Could be an abscess.
Let's say it's not a cyst. Yeah, exactly. Yeah, especially if somebody's just coming in, they got like repetitive injury pain. Is these paralabral cysts are really common when you get tears of the labrum and you get this kind of like leakage of the synovial fluid outside of the joint itself. So if you see these little doop doop doops, and you can see them like, and you can see them kind of like anywhere that that's contiguous with synovial fluid. So you can see them in the glenoid socket. A lot of times they'll be like an associated tear like right above them, but if it's something that's older, you might not see it. But it kind of can clue you into that they've hurt their labrum there too, and you get these little like ovoid cysts there. And that's like the whole ASAP protocol for like what we really will be looking at when we're looking at the like the rotator cuff area and just causes for shoulder pain. And then I wanted to kind of separately include shoulder dislocation because that's, I think, something like really bread and buttery from what we're doing. So what's this up here?
Let's see, humeral head.
Yep. And then what's this?
That's the
AC joint?
none of these joint. Is the actually like
Yeah, you're in the back here. Yep. So that's actually this. So that's the like the scapular spine and the glenoid. And then up here is just like muscles of your rotator cuff. And like we'll see some images, but it's really like very easy in my mind to do these ultrasounds because like the vast majority are going to be these anterior dislocations. So your humeral head is going to disappear. It's going to go further down the screen because it's going more to the anterior of the patient and you're scanning them from behind. So you're going to just see the humeral head sitting very deep in the screen, and the occasion that you will see a posterior dislocation, because it's posterior, it's going towards your probe, it's going to be, going to be much more superficial on the screen. And this is just to kind of show that in relationship to the glenoid. And a lot of times too, you'll see like this kind of like grossness here, because that's just like hematorosis. So what do we think about this image? What do we think about? It kind of comes, you can really see it better down here. So what do we think's going on here when we see that humeral head appear down there?
Looks a bit far away. So maybe just like I don't know.
So would that be anterior or posterior?
Be anterior.
Yep, so that's an anterior dislocation because it's deep. And then like our approaches, like for if you're going to do this, is just to kind of show if you're going to find that space. So you've got the humeral head sitting low there, and then using that to guide your needle. Again, I didn't focus too much on doing the procedural side of things. We can always do a separate lecture on that and a separate lecture on other MSK things, but you already see that this is a long haul lecture. And then this is just one of the many beautiful images that you can find. What do you think is happening here, Brian? What's happening,
So-
Brian?
There's hypoechoic fluid. Was that?
You might have it there too. Like that might just be normal bursa there, but like, so you have the humeral head is here, and then the humeral head is up here. What do you think is happening in this image?
It being reduced.
Yep, this is like real-time reduction of a shoulder joint, which is really, really satisfying. All right, so that's shoulders. Any questions for shoulders before we move on to hips?
Hip.
Hooray! So moving straight into hips. So one of the things that we're going to be thinking of with when we're doing this is not to do your peng blocks or anything. This is just for looking for pathology. Is that you're going to be kind of running your probe to look up towards the femoral head. So the probe is going to be to the femoral head and to the acetabulum, which you can kind of see here. Like if this is the patient that they're sitting this probe up here. So this is the probe marker, which is going to be the left of the screen. So that's going to be the femoral head. And then that would make this the femoral neck, right? So you've got femoral head here, and then you've got femoral neck. So what do we think that this muscle is up here? No, this is just kind of, I'm just torturing you guys right now.
Is that like the obturator or the psoas?
Let me show you the psoas, right? Because it's like kind of where you're sitting. It's kind of like in that like middle part of your of your femur there. So that's going to be the iliopsoas, and then you're going to have the iliofemoral ligament. And really what we're looking for, trust me, these slides get simpler from now on out, is we're looking for a fusion here. So that area, the reason that I'm focusing so much on, you're going to find that femoral head and then you're going to find the femoral neck, is because that's where fluid likes to live for these. So like when you're interrogating for an effusion, is you're looking in that area, right around the femoral head and the neck. So simple enough to kind of like find out where we're like looking for an effusion. What about this? Do you think this is normal or abnormal?
Abnormal.
So what makes you say it's abnormal?
I mean, the muscle's like so hyperechoic, and like it looks
think
like there's a small little bit of like hypoechoic surrounding it. So
I wonder if it's partially because this is just kind of an overgained image that it's kind of making normal structures look abnormal. It's a little bit on the bright side. What if I told you that then we went to the other side and it looked exactly the same, this area of fluid?
Then probably normal.
Yeah, so there's some absolutes that you can use, but if somebody doesn't have like a high amputation, this is really the key time to look for at both hips. So the absolute is if there's greater than 7 millimeters in this stripe of fluid, or if the difference between the leg that's impacted and the other leg is greater than 1 millimeter. Does that make
Okay.
sense?
Yeah.
And that's it. That's it for hips. So like we can move on. Like 'cause it's really like the main thing that I would be interrogating. Because if we just talk about looking at fractures in general, then that's a whole other lecture. I'm trying to just focus this on the joints. So for the next few joints, which we're going to start with the knees here, which I hope you guys guessed, is because we're kind of like trying to simplify this a little bit, is if we're trying to see if there's problems with ligaments, we want to see if there's disruption. When we're looking at the menisci in the knee, if they don't look regular, and then if there's just fluid. So it gets a little bit simpler too, just for what we're trying to do in the emergency department. So you see here, like, so you've got a couple different views that you're taking. They've chosen to, in this view, which I often do as well, is to put the probe marker towards the knee. So then in that case, you'd see the patella would show up on the left side of your screen. And then right above that, you would see the quads, and you can see it kind of like tapering off and then connecting into the patella. So that just gives you an idea of where you are and where you're going to be looking for fluid, which is going to be oftentimes within this triangle here. The other view that you would want to get is if you want to go inferior to the knee, which again, now they're just focusing, they're putting the probe marker towards the patella, where you've got the patella and then you've got the patellar tendon that's inserting into the patella from that side. So you've got quad tendon inserting from up there, patellar tendon inserting from down here. Then if you just want to slide a little bit lower, then you're also able to see the tibia. So, and you can also do this from the side as well. And we'll get into why you would do this, of where this is like, I feel like this was like a little bit of a game changer because so many people like you have suspicion for, especially for medial meniscus injuries. And this is actually really easy if you start playing with this to find. Nick, have you done a lot of these where you've been looking at the side of the knee?
No,
Looking
a
at
lot,
their
but I've been doing it more.
Yeah, because I think it's like it's helpful because it's pretty easy to identify these landmarks because you've got the femur and then you've got the tibia, and then there's just a little triangle that lives in betwixt them, and then that's just your medial meniscus. So that's like, I feel like that's just like it's findable and it's a common enough cause of pathology that it's cool to be able to find it. And you know, until they get their MRI, this is probably the best thing you're going to be getting from them. Also, if you're looking at that medial side and you look kind of more superficial to the screen, is you see the medial collateral ligament that's sitting, so right down here. They're not like gained very well for the distal part of the screen to really see that area between the femur and the tibia where you're looking for what we see down here for the medial meniscus. But right above that, you'll have the medial collateral ligament. And really, you just want to see if the fibers are happy, if they just look funky or not, would be all I would really be capable of doing. And then most people that have medial sides, they also have lateral sides. And then kind of very superficial on the screen there, you can see their lateral collateral ligament. And then you can see their little popliteus tendon there. And again, like what I said before, we're looking at ligaments, we're looking at tendons, we're looking for disruption, we're looking for fluid as well. So that's really like the normal part of it. So when there's going to be, this is a classic. This like never gets old, does it? Am I the only one that thinks this never gets old? So if this is the patella here, and this is the patellar tendon, what do we think is going on here?
So the patellar tendon rupture.
Yeah, it looks like a pretty like significant, like a complete one, because you've got like edema that's like between the like more, I guess this would be the more distal because we're looking at the patellar tendon. The more distal portion seems discontiguous with the more proximal one. So, and there's been like studies too that have like shown like crazy amounts of sensitivity and from ER docs doing this. Like one like had not as great of specificity, but another one showed a specificity of 95%. So especially people like do not participate very well in the physical exam when they're in that much pain. So I think it can be helpful as an adjunct for your physical exam. And then just when you're looking at the medial meniscus, it's really like, if you kind of think about it, it should be this line that goes right across from the femoris, from the femoral bone to the tibia. It should just be like contiguous. So if you see it going above that line and there's bulging, then that's concerning that there is injury to the meniscus. So that's easy enough. And then what do we think about this bone here?
It's not right.
It ain't right. It ain't right. It's not connecting. So
No.
yeah, so you get a fracture and then you get this kind of associated mixed echogenicity up there of associated tendon injury.
Mhm.
And then this is somebody who's like trying to range their knee. So what do we think about this? So you can see that this is a dynamic scan, right?
Looks like there's an effusion.
Yep, I definitely agree. Like, and you've got free fluid, you got a fusion here. This, without even just objectively measuring it, looks like obvious effusion. Like, does not look like it's just normal like bursa.
Is this supposed to be like a lateral or a medial image, or trying to orient myself?
So if you're to orient yourself, then this would be, I think this is probably like an anterior image, and you're seeing your patella here and then your tibia here, but that's just from kind of a guesstimation here. But I think that's because this would sit higher normally.
Yeah,
And just from kind of staring at these.
and it looks like it's bunching up then a lot.
Yeah, so exactly. So you see that there's like pretty significant tendon retraction happening up there. You've got evidence of traumatic hematoma as well. Excellent. So that's your knees. And now for your upper knees, we'll just quickly go through the elbow here. So your main way you're going to want to, if you can, depending on your patient's ability to cooperate, they're just going to have their elbow bent at 90 degrees. You're going to be using your linear probe as well. So when you're trying to orient yourself here, like as with all the joints, you can go from the back, the front, and the side. So if you start from the back here, and you think about where their probe marker is, you're going to have your triceps tendon that sits like above, and then you're going to have the little divot there. You're going to have the humeral lateral epicondyle, and then you're going to have the trochlea as well. And then you're going to have like your normal fat there, which is important because really what I'm going to be doing with this is looking for effusions and looking for elevation of the fat pad, right?
Mhm.
And then in the front side, it's going to be instead of the triceps tendon, you're going to be looking at your biceps tendon. But the same kind of idea of that you're going to have, you're going to have the elbow joint, you're going to have the fat, and obviously the trochlea is going to then bleed into the ulna within that shoulder association. You can go onto the sides as well and see the radius in addition to where it interacts with the humerus. And these are just all places that you can just like in an organized fashion look for effusion. So we know when we're looking for that, like pushing that like sail sign, and we're looking for the posterior fat pad. This is actually pretty helpful, I think, for that. So if you see like a normal fat pad, like you just got kind of normal fat, up here is not disrupted. This like is just a normal contiguous tendon. You're seeing the triceps tendon that's not having any issues there. But then if you go and you're kind of drawing that imaginary line, below the triceps tendon, below the triceps muscle, you should just have this nice flat fat pad. Does this look like a nice flat fat pad down here?
Nope.
No, it's not. And this too, look at it. It's all bulgy. Not good. And then too, what do we make of this? Like, so this is not flat, right? What do we think is going on within the fat pad?
It looks like it's being elevated.
Yeah, so it's both elevated and you've got this like hypoechoic, like anechoic area. So there's probably some degree of hemarthrosis would be my guess.
Yeah.
So normal fat pad, and then like you've got these like kind of like gross bulging fat pads. There's a lot of, I didn't write it down, but there's a lot of studies for the support of sensitivity and specificity of us taking a peek at that, because you can see that's not a hard thing to appreciate.
Mhm.
And And then this has the positive fracture sign, and you see that there's bulging of the fat pad, and then additionally there's effusion as well. The thing is, and this one I couldn't get one that wasn't labeled, but so you have your triceps tendon, you've got your epicondyle, you've got your trochlea. This is where you're looking at for like effusion and fluid. So if you're seeing something, especially in my mind, if it's like above the triceps tendon and you're seeing a fluid collection, like it's not in the joint, which means it's bursitis, right? Does that make sense?
Yeah.
So use the triceps tendon when you're like, oh, I see a bunch of fluid before you like hang your hat on that it's like a lipo hemorrhagitis, that it's got to live below that triceps tendon. So those are all the things I was tasked with, but very quickly for the last couple slides, just a reminder of the things that we're looking for in the ankle and the wrist, because they're also pretty simple. Just when you're looking for effusions here, oftentimes they're going to be between the tibia and the talus, so you'll see fluid that accumulates there, especially if you're going to do a ultrasound guided like aspiration. And just remember too, I don't have a just constant spaced repetition reminders that this would be the one of the few like joint taps that I would do in the transverse plane. Like I would do it in the short axis, I should say, because you really don't have room to come up from up here to do it. Does that make sense?
Yeah.
And then just really quickly for the wrist, just for thinking about where fluid likes to accumulate from the wrist, if you're on this dorsal plane up here, you're going to be seeing like the extensor carpi brevis tendon. And then you're also going to see the radialis longus there. And then you've got, you've got the bony parts of your radius. You could do the same thing in the longitudinal plane where you're going to be more on the radial side so that you're appreciating the scaphoid there. And that's where effusions like to live too. So just for just your brief reminder for those smaller joints of just where you kind of want to look for effusions. On the ankle, it's going to be between the tibia and the talus, and in the wrist, it's going to often be between the radius and the scaphoid. And then I put all these in here for when I send you these lecture slides so that you have a lot of the sources that I used to make this.
Awesome. Thank you.
Sorry, that was a lot, I know, but
No,
it's
no,
a
it was
lot
good.
MSK is like a really broad thing, so I tried to just focus this on the joints, but get a little more granular than some of the like very basic stuff that we do.
No, it was good. Definitely a